talk. And what I'll tell you about this Mentimeter, if you've not used it, is that once you get on, you can download the slides, but also I'll download all of the slides at the end, which will have our interactions on it. So I am thrilled to be here and talking about a topic that's really important to me, probably very important to you too. And I hope you've all had a chance to review the manuscript, our SI-CBPAR, Structural Indicators of CBPAR. Today I'm going to talk about what I call the praxis of engagement. When I teach CBPAR concepts to others, whether they're students or colleagues or what, it not only includes what constitutes CBPAR, but also about the process of continuing engagement, learning, improvement of that relationship that is inherent to CBPAR. In essence, CBPAR isn't one-off, and it isn't focused on one and done or one project. So I'm going to turn it to you all for discussions and questions, certainly, but I want to have you watch the chat. So if there's a question that's burning, flag me and be like, Beth, answer this now, and we'll absolutely do that. So what I want to do by way of understanding everyone is to introduce you this concept of Mentimeter. You can use your computer to get to Mentimeter using the URL at the top of the screen, and typing in that little document, the code of 687897776, or you can scan QR code at the bottom. And I'm asking you to tell me a little bit more about yourself. I realize these are terrible categories for everyone, but give me a sense of your primary role. Are you a researcher first? Are you government or foundation? Practice? Are you in clinical or public health practice? Are you a community partner to research? You might be in practice as well. How would you identify yourself? And by the way, if you teach large classes, this is a really good way to get students whose eyes are in their phones too, engaged in stuff. So good, great. Oh, okay, great. I'm going to give people a chance to get on because it takes a minute. Now, once you're on this, you can see the slides as they're presented. This will be the last time I show the access stuff. So I just want to make sure I'm getting a chance to see everybody. We've got 19 people so far. Christine, you want to tell me when you think you have everybody? So good. Research mostly, community partners, great. Government. Has everybody had a chance to get on? It takes a minute to populate. Great. This really gives me a sense of kind of where you're coming from. There are these little things at the bottom. You can, click on them and stuff like that. Okay, well, this gives me a sense of where you're coming from, and you can still access if you decide you want to access. You didn't before. I will certainly make that possible. So by way of quick introduction, let me first share that what our work is about at the Harm Reduction Research Lab is with drug user health. And we work in two systems. We work in medicine and we work in pharmacy. And we have a through line of engagement science and harm reduction science. So I'm going to talk with you about the engagement science because that's what the SI-CBPAR was all about. But the harm reduction science is all about characterizing and validating harm reduction classes so that we can more precisely target our interventions. Think about precision medicine. The same thing goes with intervention. Our department is the Department of Family and Community Medicine, and the lab thrives there because this department is about social justice through medicine, and we absolutely believe that that's a piece of the important puzzle. Our work is translational to policy and practice. I'll show you an example of what that means. And when we talk about building the edifice for informing policy or change, we have to ask who's change, what change, whose goals, and you'll see where we center our work and our focus. So what I'm going to do here is give you a sense of our lab. This is on the left side. Sorry, it says pharmacy on the left side, medicine on the right side. It might not come clear. Sometimes Mentimeter doesn't upload your slides well. These are just our studies, arrayed translational studies focused on overdose reduction. We do some studies in bloodborne illness elimination, think syringe access for the most part. And so these are funded mostly by NIDA. The incubated studies are the smaller studies that build onto bigger studies. Those are where the arrows are. And essentially what our focus is on right now is normalizing methadone. So we're currently working on moving the practice of methadone treatment from its current iteration to evidence-based person-centered protocols, which may ultimately involve policy allowing, clinician prescribing, and pharmacy dispensing. We anticipate this by a couple of our studies, future prescriber studies and methadone dispensing by pharmacies. And so we're looking to not only be here and understand what's going on with the policy changes afoot, but how we can kind of prepare for them. So as had been mentioned by Kim, we center our work on the people who do it and the people who experience it. And sometimes they wear both hats. The slide provides a description of this group, the DPRAB. None of these are really sexy acronyms, but we convene them. My lab convenes this group, which means we finance this group, financially support this group as vendors to the lab. And they're a reminder that science essentially is socially constructed, and even our power differentials, gender, race, class, caste, ability, et cetera, that defines and what constitutes science, inquiry, knowledge, importance, and even the methods that we use. So the strength of the DPRAB is that it is transdisciplinary for sure. Everybody brings experience to the table. I see myself as a plumber, hey, we need this, we need that method, blah, blah, blah. That's how I see myself. So I recognize, yes, the power is in my lab, and yes, I fund these people. But I do see myself as a technician in the group, and we curate the power dynamics and constantly interrogate them as part of our praxis, which I'll talk about in a moment. So people have experiences in many areas, and we don't assume that it's one or the other. So as we've been working together since 2020, the space has been created for even providers to disclose their lived experience, funders, government partners, and people who have come into the group with lived and living drug use experience have actually felt the opportunity to develop and to bring forth their other expertise to the table, which really, really matters. So constant conversation around the praxis here with the group. Today, our membership is 25 people. We try to balance representation. 64% are people with lived and living experience in drug use. 32% are mood providers, so buprenorphine, methadone. 32% are harm reduction organizations in the community, think syringe service, sex work, stuff like that. 9% are payers, so we have Medicaid and subs on the group. 4.5% are government, our state SOTA, our state opioid treatment authorities on the group, and 9% are universities. And I try not to crowd the researchers in there, so they come and go as dictated by the agenda of the DPRAB. So all this means that we're in praxis and we work together interrogating these dynamics, and it means really, colleagues, that we're in a relationship. And so if you're ever in a long-term relationship, friendship, marriage, whatever, this stuff takes work. And this is really the love, the work, the water, the feeding that I'm really talking about. So let me just ask you a question about your experiences, and that is, what best describes your community research relationship? Are you from communities that participate, or you have communities participating in your studies? Do communities advise your studies, or are you part of that? Are they actively engaged in the study implementation? Do the communities direct your research? Give me a flavor for and none of it's right, none of it's wrong, it just is. So think about what that interface is for you. Communities advise, communities direct, they participate, they are engaged. Yeah, that's good. And I recognize you might have several different iterations, but what is the primary relationship? Yeah, good. All right. Yeah, this is really interesting. So participate in studies for almost half, and actively engage another third. That's great. And some advise and some direct. Terrific. Well, that gives me a good sense of things. So as we saw with the Menti, there's a lot of ways to engage, and each form has implications for power sharing and ownership. So here you see an adapted continuum depicting how engagement changes from helicopter science on the left to shared knowledge and ownership through CBPAR on the right, or PAR for participatory or action research. The collective ownership moves from left to right. And what I want you to appreciate is that engagement is a practice and not a destination. So there are activities, there are actions that might place certain things around a continuum, or help you express or characterize that relationship. But it really is an engagement and a practice. So I guess the real question for you, and we have this very same question ourselves, is how do we know it when we see it? So take a minute and tell me how you know engagement by community in research when you see it. And don't worry about how this sounds. Just how do you know it when you see it? I know it'll take a minute to update too. Just take it so people show up and speak up. Yeah. Communication, that's a big thing. That's a really big thing. Safe and brave spaces. The science questions are driven directly by the community. Yeah, that's good. That's good. Yes, people want further information. They're engaged. They want to know. Variety of people, yes. Participate. Great. Oh, these are excellent. Fair collaborations. In the community. Yeah, vulnerability, willingness to be vulnerable. That's so important. Sharing responsibility. Absolutely. hmm Yeah. Oh, transparency is so big. You really are seeing it. hmm Knowing your community and the needs it supports. Yes. And there's something about your community. It's showing up. It's not saying that community and I'm not connected with that community. It's doing work in your own community. This is great. Unaffiliated people and entities show up to share. Oh, that's good. These are great.
Excuse
These
me,
are
Beth.
really good. Yes.
My name is Shay Yantis. I'm with the
Hey.
Catron County Health Council. I'm the chairman. Wonderful to meet you. There was just someone in the comments that asked if they could share the Menti code again in the chat,
Oh, sure,
possibly.
sure, sure. Let me go back. Thanks for that. I really appreciate the interruption. So the code is here. Go to menti.com, menti.com, and you're going to use the code 68789776. In fact, if somebody could put that in the chat, that would be awesome. I can't walk and chew gum. This is probably why, why I can't do it. Is that, do you have it? Is that sufficient?
Yes, we just multiple people
Awesome.
shared it.
Yay. Thank you. Thank you. No, this is great. I'm so glad you said it. And the QR code works too, but sometimes people don't want to use their phone, and I really appreciate that too. So these are all great. Things are centered around, and you'll start to see, by the way, when we download these slides after our session, these will be in the slides. So you'll see what your colleagues are saying. So thank you for that. So we ask ourselves the same questions. How do we know it when we see it? And this is and are those indicators what we say we need to see? Are they robust enough to do the job? Do they really tell us, or is this some kind of performative thing? So as you likely saw with the manuscript in drug alcohol review, which by the way, it's an open access manuscript. You can get to it by the tiny URL at the bottom of the screen if you haven't had a chance to read it. As you saw from the manuscript, these are the key domains where we think we really have thought through where those structural indicators are apart. And we've talked about indicators. There are a ton of wonderful tools: satisfaction, feelings of empowerment that are focused at the individual level. We're looking up a level or two and really talking about the way the power relationships are arrayed. And these other things matter too, whether people feel engaged and do they feel heard. These are all super important. But we also felt taking it up a notch was important as well. And note how we defined, if you recall in the manuscript, we came to this phrase called research entities. So this isn't about university and communities. This is about who controls the research and who doesn't. Who are the researchers and who are the researched? And even in the relationship when you're not the researched, who controls the decisions around the research? So that can be a university, that can be a funder, that could be a community-based organization, could be a state partner, could be anybody. And so you want to take a look at that. We talk about, Kim was saying how a feature of our lab is to develop scientists with lived and living experiences. Of course, that's not the same as having advisors and citizen scientists, which we do, but it is providing that safe space for people to develop their science, even as they're out about their own lived experience. And that's real important in university settings, which can be very punitive and carceral. But the important thing here I want you to take home is the science itself was advanced because our co-authors were all people with lived experience and living experience. So they could really challenge all of us to think about the power in these relationships, and came to a phrase called research entity. So this wasn't just about community and university, but really, really about the entity that has control over the research itself. So I'm going to ask you a Las Vegas question, my people, and I want you to be honest about it because it'll tell me how we cover the rest of the session today. I want honesty. Did you read the article? Yup or nope? I'm not going to hold it against you, but I really do want to know. Nope. Okay. Thank you for being honest. This will tell me how much I want to pause on certain things before we reflect on praxis. I will say it was a good article, but I can't really be honest about that and objective. My mother would say it was good too. Okay, so most people didn't read it. So I'm just going to unpack just a couple of key concepts for you as we work forward. It's okay. I appreciate that you said that, so we can all be on the same page. Before I unpack that, any of us who study community engagement or community engaged research or CBPAR know that engagement is a process and not a destination. It's a relationship over time and not a one-off, as I've said, though frankly, many of these are one-offs, or the relationship's about one project, so one and done. The fact of the matter is we are in a process of engagement, whether we think we are or not. So think about this. The histories of engagement come into engagement every time and as time follows. What do I mean by that? The history could be attached to a person, like the lead researcher, how they behaved in community in the past, what their identity might mean to communities, for example. It could be attached to a group like a lab or a college. I live in a state where one of our state universities misused the Havasu Pi data. If that's not history that's carried into every single engagement that follows, I don't know what is. Think about when we do syphilis work in BIPOC communities. Tuskegee is the ghost that travels with us. So it's these kinds of things. What I mean by time is not linear. It's really kind of at the same moment all the time, and that's what we need to remember about praxis and engagement. So understanding that's really an important first step. We do when we engage. We recruit members, we orient them to a process, we meet them together, we work on projects of shared interests together, and we reflect on that engagement, we hope, but that reflection may never happen. And this is really important to think about in your own work. Do you ever have that transparent, somebody else had transparency in the indicators. Do you have a transparent opportunity to really Monday morning quarterback engagement processes or reflect on them after they happen or even as they happen? That is a commitment to engagement that we make in our processes. I hope you do in yours as well. And there's no right or wrong way about it. You have to figure out how it works together and decide what that might look like. And so the real question to you is whether a process can pause and allow enough space for reflection to learn what is happening in the process so that one can decide, or a group of people can decide, whether and how things should proceed. So this is fraught with all sorts of levels of policy and power, which certainly I can refer to you to the paper to read more about. But upon learning more, then the other question remains: how do you tend to the process? So what needs to be fixed exactly? Is it fixable, or is it a space and time thing, a recognition thing? Think trauma-informed planning. Repaired, strengthened, reoriented, or whatever needs to be made permanent or made part of the customary practice of the group. How is that done? How does that become enculturated into the engagement process? And this is what I'm talking about. This is the meat of it. And so to reflect on that cycle, we often say, well, how did it go? How is it going? Do we get it together? Are we getting it together? And what do we build into our process? in order to be successful with that, we invest in the leadership of the group. So the DPRAB is co-chaired by a community leader, Arlene Mahoney, who is the executive director of the Southwest Recovery Alliance and also a sex workers union in the metro area, Phoenix area of Arizona, and Dr. Christine Arredondo, who is a mood provider working in an FQHC, but also providing service and help for Pascua Yaqui tribe. And she is a psychiatrist and addiction medicine specialist herself. So together, the three of us have our hands on how's it going with information and training, and that investment means empowering my two colleagues to do the work they have to do as well. So it's not my DPRAB, it's our work, and that group advises the lab. So to unpack just briefly, because I know many of you said, hey, hadn't read it. The big boxes that you'll see in these slides are the big domains that you saw in that first slide. And all I want to just say is each of these domains have components that are attached to them. And for example, study initiation and funding, it's about who starts the thing, whose idea was it? And, I don't bring my wild hair ideas to a group and say, hey, I want to do this in underwater fire prevention. What do y'all think? We talk together about what we're doing now and what are the missing links that we have to understand to move things forward. So we have this vision together of normalizing methadone, for example. What will it take evidence-wise in Arizona for us to be able to understand what has to happen and to move things forward? Usually my partners call upon me to help, which is why I say I think of myself as a technician or plumber, if you will. When we talk about, and that's really the study initiation. So you can think about many things. What is this? And you'll note in the instrument, which is in the article itself, it's a super easy thing to use. Is it there or is it not? Are we not sure? Is it a point of discussion for us? It's not these scalar things that you have to add up at the end and make people feel like they're somewhat imposters. This is a big discussion in our group, imposter syndrome, and feeling empowered enough to do things. So we intentionally built an instrument that was super easy to use and to apply. For coalition engagement, this is about who's engaged and also about how power is distributed through the engagement and who determines who community is. So again, a lot of researchers, myself included, and this was part of our process of writing this article even, sometimes I will assume a CBO, a community-based organization, represents the community because they are run by people in the community. But that is not always the case. And how do you check that when you have a process with a group of folks? How do you know? And how is the structure of that engagement facilitating or not people's engagement? So are we so Zoom oriented that our colleagues who are unhoused and following on a phone with very little Wi-Fi outside a library able to engage fully, right? How do we figure that out? And this is what we're talking about in engagement wise. In terms of research implementation, some of you said, hey, we have access to, we have folks who do the research implementation. Yes, that's common. We pay people to implement the research, to recruit people from their communities, and et cetera. When we think about this research engagement implementation or research implementation, what we don't think about are methods determination. Who determines how this study will be implemented? Okay, we want to study. So for example, in 2020, two of my colleagues, you might have seen in our array of studies, the MAPI study, which is the Mood Access Policy Index. That was a study we conducted funded by the Fore Foundation and Vitalist. It then fed into our new R6133 or our NIDA funded $5 million project to normalize methadone. What we found was that, so colleagues came to me in 2020 saying, Beth, things changed in methadone and buprenorphine treatment. We know it's not enough. It's going to happen and stay this way in COVID. Can you, Beth, study if it had an effect? And of course, my answer was like, no, can we do this? So we got a group of people together and just kept widening that table to say, if we wanted to understand whether this was effective or not, how would we do it? And from this came a bifocal study. We wanted to learn from people, policy experience, who were on methadone and buprenorphine. We wanted to learn from providers, policy implementation, to learn what was happening. And so the methods determination was identified, characterized, by the community. And so that is what we could do together. And this is an example of research implementation that is often missed when we talk about full engagement. Community capacity development is another piece of this. And I will talk about this very clearly in a second, but it has to do with, to what extent is the engagement meeting community development goals? Is it beyond the project? And for us, this is an absolute yes. So I'm showing you here the micro, meso, and macro examples of impacts from our process. And I can give you specific ones, certainly, but at the micro level, what we're talking about, it starts here. When people want to engage, the thing we're asking together is, what do you yourself want to get out of this experience? And I mean, that can range from, I want to help my community, to I want to get a job, to I want to get my kids, to I want to get money, whatever, right? I want to meet other people. I want to feel wanted. I want to feel smarter. I want to get back to my social work degree. But since, I've had years of chaotic drug use, that's been gone, or it's different for every person. But we have to ask that question and make sure it's our business to design the entire process around opportunities for people to develop. I want to be able to talk in front of people, for example. At the meso level, this is what needs are being expressed at the social and professional network level. So, community network level, I want our community to connect. We're from the rural area. We're a harm reduction group in the rural area of Arizona. We feel totally disconnected with what's going on with the state. We want to connect with providers. We want to talk with legislators. We need to build our professional network, etc. At the macro level, what people wanted to see was change. Are they being able to participate, to take the work we do together and translate that into information to be used in the policy process and with regulators, for example? Would we actually see systems change? And we have. Our work has been used to change 2 states' syringe access laws, Indiana, where I used to be, and Arizona, where I am now. And that's just one example, but that's part of that macro level effort. And here's the other piece for researchers here. This interaction fundamentally changes the way research is done as an activity, as an enterprise. We are all changed as a result of it, and we function and we behave differently. Dissemination decision making is a big thing. And it's not just journals, although certainly that's part of that. One of our studies, we're not quite ready yet, but we're trying to break a map, a public health map that we're going to publish on harm reduction practices of Arizona pharmacies. And this was iteratively developed by the community over the last 2 years. We had shared some secret shopper syringe data and had a kind of a red light, green light, yellow light thing for a live map. And people were like, that's not enough, Beth. We need BUP. We want this. We want that. So we went back and did a census survey of Arizona pharmacies. And now we have a live map with several things that people can actually find their pharmacy, see what's offered. I might be a provider and I'm prescribing buprenorphine to a new patient. Where do you live, Beth? Well, I live here. I don't know what pharmacies are there. Let's see if your pharmacy actually dispenses buprenorphine. Oh, it doesn't. Oh, there's one a mile away that does. And so these kinds of things we do, but that's a dissemination decision that is driven by the collaborative. The other thing I will say is that when we talk about dissemination, this is what the DPRAB wants to see. They want to see evidence to action, and it's really in 3 areas. So we educate the public. The map is a perfect example, but we also do public medical advisories. So we did this in June of 2023 about the multi-day dosing continuing for methadone. So we'd have a 1-sheeter that goes out to patients. The other side is to providers. A week does not go by and we're not advocating for someone around this point, but using that piece of information that was evidence-based from Arizona data. We talk with mood pharmacists and mood providers about community needs and the law. We advocate, which is not a dirty word, really encourage the state of Arizona to embrace the upcoming federal mood flexibilities, which are no longer upcoming. They're actually now in the final rule. And tomorrow night, our state opioid treatment authority is going to tell our DPRAB that, in fact, Arizona is going to embrace that, which is a big win. We worked with Medicaid using our hepatitis C study data as a DPRAB to remove barriers to curative treatment. So you can start to see where we're using data to make a case. Data becomes information, which becomes a case to be made that advances community goals. The empowerment piece is a very specific one. We advanced a group called the Evidence Ambassadors, and that was funded through a grant from Vitalis, not to the university, because I didn't want a scratch and sniff problem where people are saying, well, there are people who are doing lobbying and they're part of the university. Nope, they're part of a CBO that trains people from the community, mood providers, people on mood, people who are living with drug use experience, don't want to be in treatment. They are trained as advocates to use evidence to communicate to policymakers to advance the priorities of the communities. At this point, it's normalizing methadone and achieving multi-day dosing. It's also solving a vendor issue around transportation. That's been a real big issue for folks in the community, but there are other things as well. And so that gives you a sense of our dissemination and what that looks like. All of this should be telling you this is about power. Yes. And so while we have we have a whole area called power sharing, it really is a theme that is woven throughout our work together. And it's all around how I use the privilege of where I am. And I don't mean I, Beth, I mean any of us as members use the privilege of where we are to advance the work. It is not lost on me that I'm a professor of medicine in a medical school. Not lost on me. I use that all the time. And we use the institutional access, open access publishing, grant writing, IRB to advance the work of the group, to train people, the vendor system so people can be paid in something more than gift cards. Our community partners use their own institutional and privilege and power to make cases and make way for one another. And so this is really what we're talking about when we're talking about power sharing, though in the article, we certainly gave good examples. So I didn't want to go too fast for you, but I wanted to leave a chance for us to really talk about things. But this is my information, and it'll come to you when I send the slides to Christine after we're done. But I want you to feel like you can reach out anytime and get to us to talk about what's important to you, and just know that you've got folks in a neighboring state who are at this also and interested in what you're doing as well. So thank you for this chance to share with you just a little bit about what we're doing, and I'd be happy to hear a conversation and be part of it.
Thank you so much, Beth. This is really, really terrific. And I'd like to open it up for the group for questions and comments. There was a lot of rich stuff in here, and we have some time for everyone to chime in. I have a question, Beth, but this comes with my research hat because I was reading I guess it was the macro, and you talk about really changing the research process itself. How do you do that and maintain generalizability? And, because research is supposed to be something that benefits more than just a small group. It's, we want to be able to replicate it. How do you do that and maintain rigor and reproducibility?
Oh, sure. I don't think it's one or the other. I don't think it's binary in that way. So I gave you the example of my colleagues that came to me in mood and said, here's the problematic, you do a study. My answer was, we're doing a study. Let's figure this out together. And so, remember, I'm coming in as a technician. So I've got the research hat on. But what's the difference between me saying, what's your research aims? And me saying, well, what do you guys want to do? What do you want as an outcome? You really decide that the Research Act is one of education and bringing people at the table. And someone might say, okay, and so I would ask, well, how would you know that? So for instance, let's take the mood example. So people were like, okay, we need to know if this works. Okay, great. Let's walk through it. And we're all on Zoom because it's COVID, right? So we got the whiteboard up, and, it's a little confusing. Well, how would you know if it works? Well, people would say, they have these multi-day doses. They would say they have this, they would say they have that, blah, blah, blah. I'm like, oh, that's interesting. That's a policy experience study. We could track that. Okay. So you get where I'm going here? So we're like, oh, you're saying this. If I translate it to French, it sounds like this. And so, but really accessible still. So we do a policy experience study, and this is what we do. So in the methadone study that we have now called, and it is MPACT, methadone patient access to collaborative treatment. It is an R61, which if you guys are familiar with that, it would be a small grant funded by NIDA, a 2-year kind of demonstration, collaborative development grant demonstration and pilot, followed by a multi-year trial. So in this case, everyone is building the plane while flying, we say, building the plane on what would this look like. We all designed, we already knew what we wanted as pieces. That came collaboratively. Again, not a binary, that won't be reproducible. We're developing this right now. We will pilot test it in 2 Arizona clinics. We will then refine it further and field trial it in 30 clinics across the country among 600 patients and 479 methadone staff. And again, using statistical methods that are rigorous. So that's the difference. It's kind of like somebody talking with me about some of the social arrangement of sex work in a particular area of the community and how that interfaces with the safety of the trap houses that are right next to a certain neighborhood. I can listen really carefully. I can follow it. I don't know it, but they're the ones saying, well, here's what you're thinking, Beth, but I'm going to translate this to French so that it's understood in this context. So I don't think it's a binary at all. And I don't think research owns the rigor. And I think that's the important part. Because honestly, science is socially constructed, and it doesn't mean everything's all willy-nilly. It means we actually decide what question to ask. And that is a social process. So I think you're well within okay to see it change, and I think everybody's different. You have to decide for yourselves. This is what I tell my colleagues. You have to decide for yourself how comfortable you are in this process, because many of my colleagues, so we have a transdisciplinary group of people across 7 universities. So we've got medical sociologists who are all kumbaya, man, down the rabbit hole. Great. I have traumatologists and psychologists who are like, I was trained in the black box with validated scales. You're making me nervous, Beth. The public health people who are like, yeah, I can deal with the scales, but I could do something else. To economists who are like, we're counting. So this is kind of how we're going. It's a bit of a circus. But you can see where our training kind of makes our sight, funnels our sight in a certain way. So I guess that makes me not just the plumber. I must be the circus person who directs the circus. But my role as the lab person is to challenge my research colleagues who have all this privilege to be like, stop. Let's look at the literature and see what's rigorous in the process that our partners are recommending in what we want to do. And we have not come to a problem yet.
That's
I hope
great.
that makes
We have
sense.
some questions in the chat, Beth, and they're kind of related, but you can read them. What were some of the challenges of working with the advisory group, and what did you put in place to ensure safety of the members who may be vulnerable to surveillance and violence? And then there's another one that follows from Teresa Winstead about navigating the experience of an advisory board wanting to develop an outcome that isn't possible. So they're not really related, but they are in that we want to know more about how you navigate with your advisory board.
Yeah. So first of all, DPREP's not an advisory board, though I think probably we're hearing that. They actually drive the research of the lab. I'm not coming up with ideas and telling them about it. They're telling me this is what we need to do. We started with the MAPI project in 2020. And that was good because I had moved to Arizona. I was in Indiana, and then we were in Switzerland with my wife's job. And then I moved to Arizona in 2019. And so I believe doing CBPAR, you show up in the community first. And then if they want to work with you, they work with you. I don't set up shop and say, gee, I'm a researcher. Where's my community? Where's the community? So the good news is I was already working on syringe access with groups because I had done this in Indiana. So we had some overlap right here. So by the time 2020 came, they were like, oh, we know Beth, we know her. So they came and we talked about this study, and we built the DPRAB, not as an advisory group, but as a directorship. Think of it as board of directors. And so literally that's the lab. I get that I pay them. So we're a little sort of pregnant on that matter. And in medicine, I should know you can't be. But what I'm saying is that they really do direct the lab. And if I just haven't found the time where I'm like, I really need to look at this. What do you think? Because usually our conversation is all around the advancement of the science. So the challenge, that hasn't been a challenge, but I just want to clarify language and how I understand this board. It is driving the work of the lab. And the good news is I get hit by a bus, they're going to keep the work going, right? They just replace the bell, which is very good. So the second thing is, in terms of challenge, we had to learn in praxis. I really appreciate this because the groups, various populations in the collaborative have different trauma histories, especially when you put folks together. And while we planned the project to evaluate the impact of COVID accommodations on access to methadone and buprenorphine, the way we work is we do the research together, we plan the research, we write the grants together, we fund it, we et cetera, et cetera, et cetera. And now it's time to learn the data. We did the patient data first. We evaluated the qualitative data first and talked about what was important. The second study came second. It just happened to be the timing. And that's where we learned we had to have a different kind of process that was more trauma informed, because the people who were experiencing or had experienced the treatment system as carceral or at all had a hard time providing their voice to something when they're normally very vocal. And when there was conflict between the providers that were on our DPRAB, who are socially constructed. I mean, think about social, the social construction of American medicine. I train doctors and residents. I know they're socialized to have to know the answer all the goddamn time. And I'm like, please, I don't know is a perfect answer. In fact, you're smarter when you say that. But all their lives, they've had to know. They had to be the A student, had to all of that. So these are our colleagues that we love, but they didn't know how to not know the answer and pause for that. So we interrogated this issue as a group. We paused the process of reviewing the data. We stopped. And the leadership, so me, Cristina Arredondo, and Arlene, and several colleagues in the DPRAB from various communities got together, talked about what we heard, what we saw, what we want to do about it. It took some very independent reaching out for folks to understand what would create better trust. We did some parallel processing as a group and actually decided to look at data separately, hand our thoughts to each other. And finally, we moved back together to talk as a group, and that has been part of our work. We built other things like check-ins and a buddy system. And of course, after every meeting, there's an anonymous survey. Most people use it when they have trouble, but we certainly have it. And what we did with MPACT then, so fast forward to our NIDA funded grant, is we decided to, instead of having a group that looked like the DPRAB of people on methadone and providers on methadone building this intervention components, we separated them. So we run one group of people who have been on methadone for the last 5 years, building the components, one group who are from 3 different clinics across roles. They have their own power issues, to worry about, and anonymity and protection too, building it, and they hand the work off. So we built a system that was more trauma informed. Is it perfect? No, but we absolutely know the commitment is to understanding how it's working for everyone. So it's that. I'm so happy you asked that about how we navigate, because it really is hard, Lisa. And I think that safety is an issue, and just because I happen to be nice doesn't mean I'm safe. And so I think building those spaces it's super important, and it's not perfect.
I'm sorry, I think I might have got the order wrong, but Teresa Winstead
sorry.
asks, how do you navigate the inevitability that some of important things that need to change are beyond our control, that maybe your community groups want to study something which is not really possible to develop? How do you navigate that? Thank you.
Well, we haven't had that issue. And some of it is that we do a lot of really just street training about research. So I want to say it was 2020, maybe. I have a study out there on healthcare abuse by urgent care and hospital folks, and we did it with the Drug User Union in Phoenix. And so we met outside the back of a restaurant for weeks to plan a study. But part of that was helping people understand what could we do and what couldn't we do based on the questions they asked. So it's always in conversation, and it was never up to me. And so it was a matter of trying to figure out what could we pretty much learn, and what did we already know of fact from other studies, et cetera, and what was too far afield to understand. And we just haven't had that inevitable, if you will, using your word, problem. We find it more in the policy process. And again, education, I'm a policy trained person, so education about those, little steps toward policy change and administrative policy, little p, big P, has been a big part of our work, so that people can't just say, hey, because a lot of our coalition is part of the get rid of the clinic method movement, get rid of the clinics altogether, normalize like Australia. And that absolutely makes some sense. I have a Fulbright to figure that out. The second is impact, which is kind of that middle ground, which was to make whatever clinics we have safer for people and better and standard of care. And so I think it's really just trying to figure out together what's possible. But I've not had this problem where, we've had people say, it's got to be green, and green is impossible. I think it's really all in conversation so far. I could be wrong, and I'll have to come back and tell you if that happens.
We have a nice question from Shay Yantis, who says, how does this plan adjust to a community of 3,500 people with no hospitals in a huge county in New Mexico? So I think, I would just say, how do you scale this up or down depending on this kind of, the underserved and the many gaps that we have in our states that are very similar? So how do you scale it?
Well, this group is a statewide group. So they have purview over the whole state of the research that we do in Arizona and actually elsewhere, because and we'll add to other groups when we start our trial phase for the MPACT grant. So the scaling, I think, is a conversation you need to have with your partners, because it really depends upon who are you as a coalition and what seems right-sized. There's no right answer. So I think we've found the magic number is 20-ish, 20, 25 people on our call. Seem to be really active and engaged and can do this work. And then we do some sub works. So we might have a subgroup that recruits other people to work on something like methadone storytelling for what we're going to do as a patient journey mapping as part of our impact. So that doesn't have necessarily a bunch of DPRAB members, or the evidence ambassadors was a breakout group from the DPRAB. So in that way, it was sort of a model like that. Well, we didn't do, it's too big or too small. We never said it was too big. It was just that people thought they wanted to focus in a little bit more beyond the task of the DPRAB agenda. So I think that's a conversation you really want to have with your partners for sure.
Another question.
By the way, I'm going to drop the slides in the chat for you from the Mentimeter, so you can see them and have them, and I can email them too after the process. Certainly.
This is a question from someone from the Department of Health. How can we more effectively ensure that participants are not unduly induced to participate in studies they may otherwise not want to, especially when there are challenges when keeping track? And anyway, you can read that in the chat.
Yeah, but I see. Yeah. Well, let me ask you, let's have a conversation about this. What might be indicators of this problem? Let's start there. So whoever raised this question, let's have this conversation. Is that Lee who did? Are you willing to engage?
Yes, sorry. Can you hear me?
Yeah, no, yeah, totally. So let's talk about you're coming from a place where you obviously have this hunch. Follow it, Lee. Let's talk about it. What do you think would be indicators? Like, what would tell you that there might be this pressure?
Yeah, I mean, to me, and I've seen this happen in my work, is high drop-off rate. People halfway through are being like, I don't really know if this is for me. Maybe they've participated and there is, you get part of the incentive early and then part when you finish and they get the first incentive and then they drop out because they're maybe not really feeling it, or they have something else come up, right? They are participating in this and are not actually able to commit to the level that you need, where you want them to participate in this, but you haven't accounted for the fact that maybe they have an appointment to go to, or maybe you're being too strict. And I've had this happen. I was working at I ran a COVID isolation clinic at a homeless shelter here in Albuquerque. That was my contribution for most of the pandemic. And there were folks coming in doing like vaccine incentives, for instance, and then offering I forget what exactly the incentive, but it was a really nice lunch and then some kind of like gift card for when they go. And like that incentivizes people maybe to lie about their vax records, right? Because because the lunch at the shelter maybe isn't so great, or maybe they don't like it, or it doesn't meet their dietary standards. So, I did get vaccinated a month ago, but I'm gonna get a nice lunch today and I'm gonna get an extra vaccine, right? And it's hard navigating those things. I mean, one, I didn't have quite a hand in that. Right. This is somebody else coming in, a partner service coming in and doing this. But also, it is difficult counseling, like trying to counsel participants in that are like coming to me and being like, hey, what are they doing? What are they here for? What's the incentive? Like, do you think I should do it? And I'm like, so it's challenging, especially when like I was saying, especially when for them, they may not really see a reason to turn it down.
I got it. So do you have a kitchen cabinet around you on this project, for example? Do you have a group of people from the population that you are hoping to recruit around the table as colleagues thinking about this project with you? If you don't, I don't want to put you on the spot, Lee. If you don't, I recommend it. And you invest in that. This is part of kind of feasibility research as well, that if implementation science is what I also do. So you're really kind of you're looking at feasibility questions, the ones you're asking right now, like, would we really see the rigor? Would we really see this if people actually do this? Or is the incentive actually counteracting, our findings, blah, blah, blah. I would really start with who's advising this study, and to what degree do they represent or reflect the population that you want to recruit? That's a good start. And then you can say to yourself, well, not really, which is probably most research, don't feel bad. But then the question would become, okay, let's talk 6 degrees of separation, the Kevin Bacon thing, 6 degrees of separation. Who do I know that might help me talk with somebody? I could go to the shelter, buy lunch for like 10 people, and we could talk about this concept and then give me feedback about what would they, and I could develop a relationship, see if anybody wants to be involved, get to know people. You might show up already as a volunteer. That's a good thing. But if you don't, it would be a matter of engaging people as the advisors, as people who could tell you what is necessary and what would undue pressure look like. And I think you'll find you'll have better science and better engagement, frankly, probably, is my hunch.
Thank you so much,
I want to watch
Beth.
time.
Thank you. We had, and thanks to everyone for your questions. It was really terrific. I do recommend the article and the checklist. I just think it's so pragmatic, and you'll be able to reach Beth through her contact, which is in the chat. And thank you all for coming and making today a very interesting, talk. We have a lot to learn. Thank you. Thank you, Beth.
Together. Yeah, pleasure. Please don't hesitate to reach out. Thanks a lot for the invitation.
And Beth, would you mind staying on for a moment?
Did she leave?
I think she did.
Oh dear.
Oh.
Well, bye everyone.
Okay, I'll send an email.
Okay.
Thank you. Bye, everybody.